very much, Anita. Marcia's helping me out because I just totally can't handle this computer. Thank you. I would have to go after two excellent speakers and before a really excellent speaker, but I'm going to try and do it anyway. I'm going to reintroduce myself. I'm Harris Silver. I'm a retired ear, nose, and throat and head and neck surgeon. And I'm really glad for the first time today I heard recovery, because I'm in recovery for 23 years. I got into recovery 23 years ago, and I was telling you about being a doctor because I was in my residency training as a surgeon when I ruptured a disc in my neck. I got a bad outcome, and I got chronic pain, and I got addicted to pain medicines. So I'm a recovering opiate addict. I say 23 years, but I had a big, fat, painful relapse in 2001. Luckily, it was a short-lived one, and I turned myself in, went and got more treatment, and came back. And as Tim said, this disease is prone to relapse. And thanks to the guy I'm looking at right here, my story was in the paper a couple of weeks ago. I was feeling a little vulnerable telling it, and that guy's story was in there too. I guess I can say that because he already put it out there. And anyway, so we talked about our recovery. It was nice to talk about recovery for once instead of talking about addiction and all the negative consequences and all the overdoses and all the terrible things that happen and the DWIs and people being incarcerated and all that stuff. Recovery works. That's why I tell you about this. Recovery works. And we can't measure the success of recovery by how long it is to the first relapse. Recovery is a process. So anyway, that's all I want to say. I want to talk about the Mental Health Parity and Addiction Equity Act. You're going to get about 2/3 of a talk I gave to the Behavioral Health Subcommittee of the Legislative Health and Human Services Committee. I think this was back in September. I was asked to talk about this. And I was also asked to give Medicaid a report card on their adherence to this. So you're going to hear that. I'm not trying to pick on Medicaid, but it's just because they're the biggest insurer in New Mexico. It was easiest to find some of their deficiencies. But pretty much, if you look at any insurance company, they have a deficiency, at least one or more deficiencies with this act. Okay, thank you. So, yeah. So just some statistics. I'm going to talk about New Mexico and Bernalillo. So a lot of you know we're #1 for alcohol-related deaths almost every year. We're somewhere between 1 and 3 for overdose deaths, but this can be a little misleading. I apologize to my Department of Health friends for giving my interpretation of these statistics, but we got down to 440 overdose deaths, but that was with 709 documented overdose reversals with Narcan. So I have a feeling our numbers are a little skewed because #1 is West Virginia. They don't have a Narcan program. Kentucky recently started its Narcan program. So I think we still have a really serious problem with overdoses. Plus, you're hearing about overdoses. And fortunately, some of those people are living through them. So I want to know how many people in the audience have heard of the Mental Health Parity and Addiction Equity Act. It looks like about 2 of you. Okay. So that's part of the problem. Okay. What's the opposite of parity? Disparity. Very good. You know, I had a big voila when I was sitting around talking about this one day, that when we don't have parity, we have disparity. And what does disparity lead to? Discrimination. And what does discrimination lead to? It leads to a lack of care usually. In the National Survey of Drug Use and Health, we are statistically tied for first for people with substance use disorders. Do both of us have top Narcan programs? We do. New York has an excellent Narcan program. Do we have a state treatment system? No, New York does. New York has a fantastic state treatment system. With residential care, you pay on a sliding scale if you can pay or if you don't have insurance. But everybody gets treatment in New York. Here we have a severe shortage of residential treatment beds. And again, the overdose ranks nationally, we're between 1 and 3. New York is between 46 and 48. Treatment is not, Narcan's not the only way to a low overdose rate. Treatment is a much more uphill strategy. with a lot less suffering if we can get to people and with treatment. So the Mental Health Parity and Addiction Equity Act was introduced by Senator Pete Domenici from New Mexico and the deceased senator from Minnesota, Paul Wellstone. It was signed into law in 2008 to correct the discriminatory health insurance practices against people with mental health and substance use disorders, which I call behavioral health disorders collectively. It's meant to curb both quantitative and non-quantitative ways that plans limit access to care compared to access for care for medical and surgical disorder, thus parity between medical and surgical disorders and behavioral health disorders in the delivery of care by health plans. So what are some of the quantitative or financial limitations that are not allowed to be more restrictive than medical or surgical care? Lifetime and annual dollar limits, financial requirements like deductibles, co-pays, co-insurance, out-of-pocket insurance, treatment limitations, frequency of treatment, number of visits, scope or duration of treatment, and must provide an out-of-network coverage if you provide that for any medical or surgical benefits. Now, there's a little asterisk they give. Plans whose costs may, if because of this, plans whose costs may increase more than 2% in the first year and 1% in the following year may file for an exemption that lets them not have to adhere to this law every other year. How about some of the non-quantitative limitations not allowed to be more restrictive? More onerous pre-authorization process, a la buprenorphine. Now we don't have buprenorphine pre-authorization process anymore with Medicaid, but it used to be pretty darn onerous. Utilization review, plan must authorize how the care is being delivered in advance. So utilization review can't be more restrictive for behavioral health. Fail first policies. So if you're only offering outpatient care or one kind of care for mental health or for addiction, but you offer all the whole entire scope of care for diabetes, that doesn't fly with this law. Is that clear? Okay. Denials or exclusion of coverage for particular treatments or levels of care. Medical necessity criteria have to be spelled out. This is where they get you, is they say it's medically not necessary. So denials of care because the service is deemed to be medically necessary to treat a condition need to be spelled out clearly. Reimbursement. Do people who do mental health services get reimbursed with people who do surgery? I don't think so. I got paid pretty good as a surgeon. So anyway, for those of you who are providers in the audience, I saw a lot of head shaking no. And quality assurance has to be done in a similar fashion. Somebody might remember a recent issue around quality assurance that happened to some Medicaid providers. Oops. So insurance plans have to comply with the Mental Health Parity and Addiction Equity Act. Group plans with employers with greater than 50 employees. They can be either completely insured by an insurer or self-insured, where the company itself insures itself but pays for an insurer like Press or United Healthcare to do their insurance for them, but they're taking all the risk. And then all individual plans and family plans in the Affordable Care Insurance Exchange marketplace and outside of it. And then all Medicaid MCO plans. So there's a couple of asterisks there. Group plans need be compliant only if they offer mental health and or substance use disorder benefits. So if they don't offer benefits, they don't have to be compliant, the group plans. The individual plans and the Medicaid plans have to have substance use and mental health disorder benefits because of the Affordable Care Act. And then compliance now includes providing residential treatment for mental health and substance use disorders. Residential treatment is included now. So who offers residential treatment coverage in New Mexico? Few of the larger employers, greater than 50 employees, and almost none of the smaller employers. Even if offered, often the benefit is denied or is only after outpatient failure, like a fail first policy. Almost none of the individual and family policies inside or outside the exchange offer residential treatment, and none of the Medicaid MCOs, except with one exception, Blue Cross and Blue Shield, offers limited residential treatment when there are certain physical diseases also present, known as a value-added service. So what are the number of, I'm doing,
It's got a mind of its own, I don't even touch it. See.
I'm doing it.
Oh, you're doing it. No wonder. I didn't realize you were clicking the thing, that's why we're doing it.
Thanks a lot, Marcia. All right.
You want to get it to that one?
Yeah. All right, so let's look at the number of residential treatment beds by state. California's got a population around 38 million. They have 18,355 beds. Ohio's got a population of 11.5 million. They've got 2,538 beds. New Mexico's got about 2 million people, and we've got about 150 residential treatment beds, and about 60 of those are CARF certified. So what's the amount of people per residential treatment bed? So in California, 2,000 people per residential treatment bed. Ohio, 548 people per residential treatment bed. How about in New Mexico? 14,000 people per residential treatment bed. If I did it for CARF certified, which is the certifying agency for rehab facilities, then it would be really bad. Next one, please. So the American Society of Addiction Medicine has patient placement and treatment criteria. Just like for people with diabetes or people who have cancer, we give different treatments for different severity of disease. And this disease, like any other disease, is not a homogeneous disease, but it's a heterogeneous disease. And people are addicted to different substances and have different severities, and they have different comorbidities and different other psychiatric illnesses. So these are all, this is the full continuity of care here. We go from early intervention up to level 3, where there's residential and inpatient services or detox, up to intensive inpatient services. Next, please. The Parity Implementation Coalition. So when they came out with this law, it was very foggy until November of 2013. And this implementation coalition came together. The American Academy of Child and Adolescent Psychiatry, the American Society of Addiction Medicine, and the American Psychiatric Association, to name a few. The main thing they were pushing for was residential treatment to be required. Next slide, please. So, again, not to pick on my friends in Medicaid, some of the violations. So as far as I know, they still do not offer residential treatment for substance use, eating, and other mental disorders for adults. They're not allowing long enough period for detox for substance use disorders if they pay for the benefit at all. They're requiring an evaluation by an independent licensed addiction specialist before approving intensive outpatient. That can lead to a 2 to 4 week delay in getting treatment after detox, which can be deadly for somebody. That's like asking somebody with diabetes and telling them they got to go to a diabetes specialist before they can get any treatment, and they got to sit around with a sugar of 400. Okay. Exclusions, exclusions from treatment because of absenteeism. They won't pay if somebody misses a treatment. Well, they don't do that to people when they miss an appointment for diabetes. Excluding all but core service agencies from being able to bill for case management, which is an important component of mental health and substance use disorder care. Next. So what are some of the accommodations to the Mental Health Parity and Addiction Equity Act? I think they did do is they got rid of the onerous pre-authorizations for opiate replacement therapy with Suboxone and Methadone. They allow for residential treatment for adolescents, usually for 30 days, without there needing to be a dual diagnosis. They're paying for overdose reversing drug Narcan, and Blue Cross and Blue Shield I had told you already about. Next. So this is an unusual violation of the Mental Health Parity and Addiction Equity Act by Medicaid. 15 mental health and substance use disorder providers were put under unusual scrutiny in their billing practice, affecting 87% of Medicaid patients. There are no similar actions of this gravity, that is, scrutiny of billing practices to even a small percentage of medical and surgical providers. Next. So recommendations. So who do you go to when there's a problem? So as of November 2013, it's supposed to be the superintendent of insurance, and if that doesn't work, you're supposed to go to the Attorney General. If that doesn't work, you're supposed to go to the Department of Health and Human Services, unless you're a self-insured group policy, then you go to the Bureau of Labor. Litigation is mostly how this has been handled. When I presented to the legislative committee, I was with an attorney. His law firm is handling cases from around the country, including 2 cases against one of the MCOs here in New Mexico. Convene a task force of providers to determine what mental health substance use disorder parity in this state should specifically look like, including how medical necessity is defined for various circumstances. And that's it. That's all I got. Thank you very much for your attention.
Is it coming? Okay.
Should just be able to go forward.
Okay.
Doesn't work.
Hi, everybody. I'm Miriam Kamarami. It's a pleasure to be here this afternoon to get to talk with you. And it's exciting to follow these 3 really wonderful presentations. I was asked to talk a little bit in response to these presentations about where we are in terms of implementing effective treatment for opioid addiction, and also what are steps forward? Where do we go from here? How do we continue to make progress and make even more dramatic progress? Because as Anita pointed out, although progress has been made, there's still an awful lot of people dying of this disease, and we can't stop now. We've got a lot of work ahead of us. I'm going to talk a little bit about medication-assisted treatment. As a physician, this has been a focus, maybe even an obsession of mine for the past decade, trying to promote physicians adopting buprenorphine treatment, because that is a highly effective, evidence-based treatment for opioid addiction that can be provided in the office-based setting. And I'm going to share with you a little bit of success and a lot of frustrations, and then maybe some thoughts about how we can do better going forward in making this happen. Wesley Clark, in Senate testimony in 2014, confirmed that although we have seen the opioid pain pill addiction overshadowing heroin addiction, as we've started to crack down on overprescribing of opioid pain pills, we're seeing a rise in heroin use again. So we squeeze the system in one place and it pops up in another way and continues to kill people. The opioid pain pill problem is also not going away. This graph is from an article lead authored by Nora Volkov of the National Institute on Drug Abuse just in 2014, in which she and other leaders called for an increase in medication-assisted treatment because it is the most strongly evidence-based treatment that we know of for opioid use disorder. And it is dramatically underused and underavailable. We've known for a very long time that treatment with buprenorphine saves lives. This study from 2003 is one of my favorites about the effectiveness of buprenorphine. What we're seeing here is, this is a study from Sweden in which they took 40 young people addicted to heroin and randomized them to either receive a brief taper with buprenorphine followed by placebo for a year, or daily buprenorphine treatment. Both groups got state-of-the-art individual counseling and group counseling multiple times per week, so they had intensive psychosocial engagement. And what you can see here is that among the group who received the active medication buprenorphine, 75% of them were still engaged in treatment, and the vast majority doing well at the end of 1 year. And from the group that received the placebo, 0 were still involved in treatment. In fact, all of them had dropped out within the first 50 days of the study. They also took note of the death rate, although that wasn't a primary focus of the study. No one died in the active medication treatment group, while 20% of the group that received the placebo died. In the intervening decade, we've accrued reams of data showing that this is an effective treatment, and in fact, it is one of the most effective medical treatments that's available in all of medicine. This study from Baltimore, published in 2012, shows the impact of increasing access to buprenorphine treatment coupled with a declining rate of heroin overdoses in the community. This mirrors what we've seen happen in France, where they implemented widespread access to buprenorphine treatment and saw their heroin overdose rate fall almost to zero. We also have increasing evidence that primary care providers can effectively use buprenorphine to treat opioid addiction. So it doesn't have to be delivered in an addiction specialty treatment setting. Primary care providers can do this very, very well. This is a study just from 2013 that shows that 60% of people who started on buprenorphine were retained in treatment at 6 months. This is a disorder with a dramatically horrific relapse rate without treatment. So achieving 60% success at 6 months is quite an accomplishment. We also, from our own colleagues, have a wonderful study from JAMA Internal Medicine in 2014, December 2014, that was lead authored by Kim Page, who's the new head of epidemiology and biostatistics at UNM. She did this study while she was at the University of California, San Francisco, and she found that maintenance treatment with buprenorphine or methadone cuts the risk of hepatitis C infection by 2/3. When you think about the impact of hepatitis C on driving death from hepatocellular carcinoma, from cirrhosis, hepatitis C is the lead cause of liver transplant in the United States at this point. The price tag associated with hepatitis C alone is so dramatic, and if you can cut the risk of new hepatitis C infection by 2/3, you can just imagine the ripple effect through the healthcare system and our society of successfully implementing medication-assisted treatment. We also know that as expensive as buprenorphine is, treating with buprenorphine is far less expensive than providing no treatment, just in terms of medical costs alone. I wanted to share with you one brief case study. This is a patient who's in her mid-40s, who I've had the opportunity to work with in the last year. She has a very severe lung disease that causes her to be on oxygen treatment. And at the time I started working with her, she was being prescribed high-dose benzodiazepines, tranquilizers, for a lifelong anxiety disorder, and she was being prescribed high-dose opioids for pain in her chest. She spent most of her time in bed. She had had a lung clot, probably caused by her immobility, and she was hospitalized literally every 2 to 6 weeks year-round because of pneumonias and respiratory decompensation, just meaning respiratory failure, that she was unable to breathe on her own and had to be put in the ICU and put on a respirator, a ventilator. When she was able to be mobile, she walked only with the assistance of a walker. After working with her for several months, working with me and the team that I work with, she was willing to consider that it was possible that the medications that she was taking were playing a role in impairing her breathing and causing her to have respiratory failure and develop pneumonia. She was very frightened of stopping both the benzodiazepines and the opioids, and I insisted that she taper off of the benzodiazepines before I would start her on buprenorphine because the combination is fairly dangerous. I worked with her, with a therapist, working with her as well to help her to cope with her anxiety and to try some non-addicting treatments for her anxiety. And we successfully tapered her off of the benzodiazepines she had been on for many years. She then transferred from the high-dose opioid analgesics that she was taking to buprenorphine. At this point, she does report some ongoing anxiety and some ongoing chest pain, but she's been able to turn her oxygen way down. She has stopped using a walker, and she's out of bed every day. She goes to the pool and swims on a daily basis, and she has not been hospitalized in the 5 months since she switched to buprenorphine. She says that she feels more alive than she has in years, and she is applying for jobs and actually has a new boyfriend, first boyfriend in many years. So it's this kind of story that keeps me doing what I'm doing, because it's pretty amazing when somebody gets their life back after being in the claws of addiction. So the evidence for the benefits of treatment with buprenorphine naloxone is overwhelming, and needless to say, the benefits of treatment with methadone are also overwhelming. Through Project ECHO, we have done extensive outreach to primary care providers in New Mexico, and we have trained more than 350 physicians. In combination with other trainers, more than 500 physicians have been trained and certified in New Mexico to prescribe buprenorphine. We at ECHO have given out over 10,000 hours of continuing medical education to medical providers in the last few years as they've participated in our Integrated Addictions and Psychiatry Tele-ECHO program, in which they present cases, get mentorship and feedback on management of these patients. And yet, last year, only 144 physicians prescribed buprenorphine to 10 or more patients in our state. And we know there are more than 2,000 primary care physicians in the state, so only a tiny fraction of people who could be doing this work. So with all of these good reasons to treat and all of this support, why don't more primary care physicians actually prescribe buprenorphine naloxone? So there have been quite a few studies of this at this point. One of them was just last year by Hutchinson. And she found that among physicians who actually have the license to prescribe buprenorphine, not prescribing is associated with having no practice partners who prescribe, lacking support from their institution, and having a lack of psychosocial resources available to them. So what do primary care doctors experience when they actually become buprenorphine prescribers? I'm going to tell you about this because it's actually not a really pretty picture. It is, in general, very difficult to do this treatment in the current treatment environment. So if a doctor wants to treat opioid addiction, in spite of it being an incredibly common and life-threatening disorder, physicians are required to take a special 8-hour course. This is not required to use any other kind of medication, including chemotherapy. And they have to get a special license from the DEA, which is also not required for any other single substance. There's a lot of extra paperwork, as Harris mentioned, prior to our working with Medicaid to remove the prior authorization requirements. Prescribing physicians would tell me that someone on their office staff was employed 1/4 time doing the prior authorization paperwork to treat 30 patients. A physician's medical judgment and the patient's success may be undermined by restrictions on dose and duration of therapy imposed by Medicaid and other insurers. Physicians typically get little support from their clinic administration or their practice partners for doing this work because of stigma, ignorance, and fear of decreased productivity. There are limits on the numbers of patients who we're allowed to treat, as though we would do something irresponsible if there wasn't a patient limit. And there is no organized system to support primary care physicians in providing this very challenging and lethal disease treatment. For example, by systematically linking primary care providers with addiction counselors or specialists. And one of the things that is most galling to most primary care physicians when they do this is that they are virtually guaranteeing that they'll be audited by the DEA. I could prescribe massive quantities of deadly drugs like Xanax and oxycodone, and I would almost assuredly not be audited. But if I start prescribing buprenorphine, the DEA is going to show up at my office within the next year in all likelihood. And almost every prescriber I know in New Mexico has been audited at this point. Being audited is a pretty creepy experience, even if you have nothing to hide. DEA agents show up in your office and flip open their badge. They're unannounced. They shut down your clinic for that, a couple of hours, and your patients are alarmed and frightened, and so is your staff. So it, needless to say, is not a positive experience. So really the question is, why would a primary care provider choose to do this work in this environment? So I think we really, if we're serious about expanding access to medical treatment for opioid use disorder, we need to start doing some things very differently. However, in spite of that rather grim assessment, there are a lot of good things happening, as you've heard about earlier in this afternoon. I'll go over just a few of them, and you've heard about some others from the group that's spoken before me. Opioid treatment programs is the official name for methadone clinics, and they are able to prescribe buprenorphine. They've actually been able to dispense buprenorphine since it was first approved back in the early 2000s, but regulations were changed so that now they can write a prescription just like an office-based provider would. So all of a sudden, opioid treatment programs are a really viable source of convenient treatment with buprenorphine for the average patient. So that's a really positive development. And I think partly in response to that, there are increasing numbers of opioid treatment programs nationally and here in New Mexico. And some of the programs that are appearing here in New Mexico are doing a great job and are really motivated to help patients to get into recovery. There's also a Senate bill, federal Senate bill that's designed to allow nurse practitioners and physician assistants to prescribe buprenorphine. This bill is sponsored by Senator Markey from Massachusetts. I don't know that it stands very much of a chance, but it's the first time that this kind of thing has been introduced at the federal level. Within our own state, I think one extremely important positive development is the expansion of Medicaid coverage. Governor Martinez did not have to decide to do this, and I really give her credit for the decision to expand Medicaid. It is having a demonstrably life-saving effect, as many folks who did not have insurance coverage or access to medical care are getting covered. It's extremely exciting, and it also means that the majority of people in our state who actually need medication-assisted treatment now have a way to pay for it in one way or another, through private insurance or through Medicaid. There is a plan by the state to enroll individuals prior to release from incarceration at all levels, to enroll them in Medicaid, and that will be a tremendous step forward, allowing them to get access to treatment as they leave incarceration. The removal of buprenorphine prior authorization requirements by Medicaid has been really huge, and the credit for that goes largely to Dr. Ann Foster and to her boss, Julie Weinberg. Medicaid coverage for methadone and for Narcan. We were one of the only states where Medicaid did not cover methadone, and the decision this last year to start covering it is a very, very positive development. Unfortunately, a substantial proportion of the opioid treatment programs are not accepting Medicaid as coverage, so that's something that I think we really need to push on. That's unacceptable, and doing the legwork to get Medicaid contracts is extremely important in order to further expand access to treatment. Locally, as I mentioned, we have expansion and access to opioid treatment programs. The nonprofit Healing Addiction in our community, led by Jennifer Weiss-Burke, is preparing to open a transitional living center for addicted youth, and we're hoping to open that by this summer. The recent collaborative task force on mental health and addiction that involved state, county, and city representatives at the initiative of Maggie Hart Stebbins, thank you very much, is really having a big impact. I think it brought together a lot of people who don't usually talk to each other and identified a lot of common strengths and common goals to allow folks to work together. As Bill mentioned, 69% of county voters, or maybe it was Mike who mentioned this, supported raising the gross receipts tax by 1/8 cent to support mental health treatment. And this would generate $20 million a year if it gets implemented. And people want this. We need to do this. City funding for housing and mental health services for people coming out of MDC and who are homeless. Thank you, Isaac Minton, for your role in making that happen, is also a very big step in the right direction. So I think we're in an environment where many good things are happening, and we don't want to lose track of those and become overly discouraged. I think we should take heart from the good things that are going on and move ahead. We need to leverage these developments and the work of this committee in order to catalyze system-level change. One really important piece that I've started to realize is that trying to twist the arm of individual physicians to prescribe buprenorphine to treat opioid addiction or any addiction is not effective, and we actually need to be talking to the administrators. If your boss is not wholeheartedly committed to treating addiction as a major health problem that deserves the same kind of attention that diabetes, high blood pressure, and cancer deserve, then you as a physician are not going to have that focus. So I think we need to be having direct dialogue with the CEOs of the federally qualified health centers. Many of them are doing good work in this area, but there's a lot more that could be done. Medicaid expansion means that these patients are primarily paying patients. So we're no longer, it's not asking them to do a charitable act, it's asking them to do the work that they receive public assistance to do. They are federally and state-funded healthcare organizations have an obligation to meet the public need, and we need to pressure them to do that. Who are the administrators who need to be at the table? Certainly the CEOs of the federally qualified health centers, CEOs of First Choice, of PMS, of Albuquerque Healthcare for the Homeless, hi Jenny, and others, many others around the state for that matter, need to be involved. CEOs of opioid treatment programs need to hear from us that we want them to accept Medicaid, that we want them to expand access to buprenorphine as well as to methadone. Leaders within the Department of Health, in spite of sometimes precarious budgets, our public health officials are very interested in promoting the health of the community, and if we reach out and collaborate, we're likely to have much greater success. UNM's ASAP and mental health center administrators definitely need to be at the table addressing these issues, as well as leadership from the city of Albuquerque and Bernalillo County. So what should we be asking for when we get all these folks sitting with us in a room? All publicly funded healthcare organizations must provide treatment for opioid use disorder. Physicians should be required to have buprenorphine certification in order to be credentialed as a primary care provider in our publicly funded healthcare systems. We should require all primary care providers to treat at least 30 patients with opioid use disorder. A lot of physicians don't want to do this because they don't want to be swamped. They don't want to be the only one in their clinic or their community who's treating this disorder. If everyone pitches in, then nobody gets overwhelmed. And all publicly funded healthcare organizations need to take a role in coordinating medical and psychosocial treatment for these disorders. The city and county must collaborate to fund coordination and provide effective referral and treatment for opioid use disorder. As Mike mentioned, we have the seeds, the kernels of this collaboration in these systems, but they don't work well together and they don't do enough. They also don't talk to the University of New Mexico directly. And so if a patient shows up at UNM, they're not necessarily going to hear about the services they would hear about if they went to the MATS or our other triage and referral sources. We need to be providing medication, counseling, and service coordination, also known as case management. Program funding must be provided through implementation of the 1/8 cent tax or redistribution of mill levy funds. Medicaid funds alone are not going to be enough to build an effective, coordinated system. They pay for the care of an individual patient, they don't pay a lot, and we need overarching funds that can pull together the system and bring everybody together under the same umbrella, so that no matter what door you walk into, you learn about all the available services that you need to get access to. So in closing, I would just say, I think it's worth imagining what an ideal system would look like in Albuquerque. And I think it consists of things like, imagine if I walk into the University of New Mexico Emergency Department or Psychiatric Emergency Department, and I feel comfortable saying, I have a heroin addiction and I need help. Imagine if I was then met with healthcare providers who said to me, I'm going to get you treatment right now. Come this way, down this hall, rather than, let me give you a piece of paper with some referral phone numbers, which is the best that people get when they acknowledge or are suspected of having an addiction in the hospital. Imagine if when people went to Turquoise Lodge or to Matt's, they always were met with treatment at the time of the request. Imagine if we had adequate residential treatment services for people who have finished with withdrawal and detox, but still need a tremendous amount of support in order to stay in recovery and get their lives back. Imagine if I went to First Choice and said, I have heroin addiction or I have pain pill addiction, and I was met with, great, let's get you into care today. Let's get you in with a doctor right now, instead of, we don't provide treatment unless you're already a primary care patient here. You can't get buprenorphine treatment. Or maybe we have an opening, but it's 2 months away. All of these things sound preposterous, but they're within our grasp. I think that we have the elements that we need, especially with Medicaid expansion, in order to be able to do this. And I think we need to demand it and make it happen. We can't let stigma, ignorance, or apathy get in our way. We need to demand an effective response from our elected and publicly funded officials and from administrators of all organizations that receive public funds. We know how to treat opioid addiction effectively, and now we just need to do it. Thank you. Thank you, everybody. I think we do have a few minutes for discussion. So I wonder if Mike and Harris and Anita, if you guys want to come back up, and maybe we can work together to facilitate a discussion. So you've heard a lot of information and perspectives over the last couple of hours. Tell me, I'd love to hear some response from you all. Does this ring true? Are there things that don't make sense that you think are missing? What do you think about the information that we've all been putting out there to you?
Hello, everybody. My name is Donald Hume. I am a person in long-term recovery, which means that I have not picked up a drink or a drug or been in a mental health ward in over 22 years. And what I want to say is, you know, we talked about all these people that we have connected here, you know, and who are the stakeholders that we need to bring to the table, you know, but the one thing that I didn't hear is that we need to bring our people in recovery into the table also. We need to make sure that those people that are in long-term recovery or shooting for long-term recovery have a place to go and be so that their recovery can be valued. So that I don't have to be afraid to stand up here as a person in long-term recovery and stand up and say that I am one of those people. You know, because for so many years, people have been afraid to stand up and say they're in recovery because of the stigma that is put on us. You know, let us be a part of this, you know, and I am a part of it, so I'm, you know, kind of jumping, you know, I work with Mike and a whole bunch of different people on a whole bunch of different areas. But, you know, the bottom line is that there are a lot of people in recovery that we're not grabbing the experience they have. We're not grabbing the things that they have to offer us on a daily basis to help the people that are trying to get into recovery. You know, I'm one of those people that speaks out that says recovery is not about me not drinking or using. Recovery is not about me keeping my mental health in place so that I'm not in a hospital, but recovery is about improving our quality of lives. And so what are we going to do to come together to help improve the quality of lives of those people that want to improve their quality of life?
I would just respond that I agree with you very much. I appreciate you coming out and sharing about your recovery. I think if people with mental disorders and substance use disorders who are in recovery from them don't share about them, we're going to continue to have stigma. That's why I do it. I do it whenever I can. Whenever I give a presentation, I say I'm in recovery, I'm in long-term recovery, and I'm proud to be in long-term recovery. And like you're saying, recovery to me is not just about not putting a drink or a drug in my body, but it's about emotional and behavioral recovery. It's the way I act, It's the way I live, it's the way I think, it's the way I feel, it's the way I manage my feelings, and it's all those things. And it's also being willing to ask for help when you need it, surrendering. So anyway, thank you for bringing that up, and anyone else who's in recovery, I encourage you to share that with other people also. Thank you.
I would also add that I think it's a good barometer for all of us if we're doing our job adequately as a society and treatment providers, people who are in recovery will feel comfortable talking about it.
I like things really easy. I don't like people to have to come to the ER or come to First Choice asking for help. Start at the jail. Okay, right now at MDC, they are swamped. And MDC, I've been there for 7 years. I tell you, everyone, the chiefs, the COs, everyone wants to help. And yet, where is the help? I mean, right now, we've got a methadone program at MDC, but there's 100 people on it. There's over 1,000 people at MDC now who need services, and they're not getting them. But they do get released at 4 o'clock in the morning on Roma, and then where do they go? Okay? It's winter time, and we know that when they get released, they're gonna die. Or if it's summer, they're gonna have, heat exhaustion. So why aren't the services at MDC? Why aren't they at the federal detention centers at Sandoval County? Why don't you have an office? We have an office. Come with us. Build up shop. Hang out with us. Work with us with the people when they're in MDC so they're eating, they're sober, they can think, they're safe. Come work with us at MDC and Sandoval and the detention centers. United States is the one country in the world that incarcerates most of its citizens, more than any other nation in the world. So come to MDC, work with us at MDC. That's all I have to say.
Thank you, Sharon, for those comments. And we in the initiative completely agree with you that MDC is a priority. You're going to hear from our criminal justice law enforcement group at the end today about initiatives that we're working on there. And we are getting cooperation from people at MDC. One of the things we're doing is getting people, starting to get people signed up for Medicaid before they leave, which is a really good initiative. And we're hoping that we get most everybody signed up on Medicaid after we get that program fully in place. One of the things that happened is we lost our warden, or Chief Rustin. We had been talking with him for quite a long time and had really been set up to get Narcan distributed with him. We were talking about getting people placed on methadone on the way in to MDC, not just maintained on methadone. We were talking about having a room set up for people to get signed up on Medicaid. And unfortunately, with the loss of the warden, we had to put off things. But I can assure you that the county is cooperating with, working with us, and we're having relatively frequent meetings with them about working on MDC. And it is, I'd say MDC is just about our top priority as far as anything to do with law enforcement and criminal justice. But I appreciate the comments. It's absolutely right. Thank you.
I just want to say that, well, we completely agree. We're all in agreement. We need more treatment in the jails. I would also like to send out a battle cry that people who need treatment shouldn't receive it in jails and/or prisons. And I think that's one of the initiatives this work group focuses strongly on. Thanks.
Great. How about other questions and comments? I know you all have some more ideas. Marcello.
Just a comment on what Molina is doing in terms of recovery. And unfortunately, I have to say that this is a topic that has been neglected, and I hope that it can be included in future meeting like this. So probably Donald already gave a little overview of what recovery is, but we do feel that without consumer involvement, really the process of recovery is not going to happen. And I haven't heard much about consumers in this forum. Correct me if I'm wrong, because I was in and out. So it's okay to talk about residential, okay? It's okay to talk about step-down levels of care, which we need to develop, by the way. But what is the forum for the consumer to say, this is what I want, this is the menu I like to choose from. And that's what's missing. I'm sorry, just a very emotional comment for me. So if you want to address that, I would really appreciate. Thanks.
Well, I think these are all very good comments. There's only so much you can say in 15 minutes for those of us who had 15 minutes to have this conversation. But I will say I agree 100%. The consumer voice is essential in any treatment we provide, whatever setting you're in. At Albuquerque Healthcare for the Homeless, we have a long history of community-based input into everything we do, including hearing things that you've heard me espouse throughout the day. Treatment shouldn't be in jail. It should be in a community-based setting. I don't make that up. We hear that from our clients. We have a monthly meetings where they come and tell us what they need, when they need it, and it should be the driving force of any evaluation, planning, or delivery of a treatment system. So very good point to bring up.
I have a question, just to ask anyone who can answer this. I have a lot of clients who don't want to be on buprenorphine. They don't want to be on methadone because they are physically addicting, both of them. What are my options if I want to be in treatment and I need medicine to help me in the long term, to help me not want to use opiates, but not have to be on buprenorphine or methadone?
Is that I actually don't agree that buprenorphine and methadone are addicting. They create physical dependence, or rather, the physical dependence is transferred from the opiate that the person was using previously to buprenorphine or methadone. But when used as directed, they don't create or promote addiction. They actually treat addiction. The distinction being that any of us would become physically dependent on an opiate if we took it, and we would withdraw if we'd been taking high doses for a long time. Not all of us would become addicted. In other words, would have intense craving, spend an enormous amount of time trying to get the opioids, neglect our personal roles as parents, professionals, et cetera, roles in society, be involved in trying to cut back and unable to, et cetera, all the DSM criteria for addiction. I absolutely agree with your point that there are plenty of people who don't want to be ever on buprenorphine or methadone, or certainly to be maintained on it on a very long-term basis. The only other medication that currently has DEA approval for treatment of opioid addiction is naltrexone in both the oral and the injectable form. We're gathering data on the injectable naltrexone. It looks promising. There are still some unanswered questions that longer-term studies are really going to help us to clarify, but that's certainly an alternative. And then there's plenty of treatment that is not medication-based, and many people do enter into recovery, as you know, and stay in recovery without the use of medications. Peer support through 12-step programs, through Smart Recovery, through other such programs has had an incredibly powerful effect and a long track record. And individual psychotherapy and counseling is also an excellent alternative. You guys want to add?
I'd just like to say, I've been in the recovery community in 12-step rooms for almost 23 years, and I find there's a lot of misunderstanding about medication-assisted treatment amongst people. In fact, there's a lot of misunderstanding about medication, period. Medication for mental disorders. Still, there's misunderstanding about it. I thought 20 years ago, 20 years from now, that it would be better, and it's really not that much better. There's a lot of people who just don't want to be on any medications, and they've got a severe bipolar disorder. And they're just misled. And unfortunately, I know people in 12-step rooms who hide the fact that they're on buprenorphine or methadone because there are people that make judgments that they're not actually sober. To me, if you're on a medication that treats addiction and you're not using anything else that you're not supposed to be using, you're sober. You're a sober person in recovery. But that's because I understand it. So, I think educating people is important. Educating clients is important. And going back to a previous question that Marcello says, I'm going to say that, and having been a doctor for a long time, patients don't always know what's best for themselves either. They don't always know what's best for themselves. And they don't always know the power of addiction, and especially heroin addiction. You know, what I tell people is when they go from prescription opioids to heroin, they've gone from a monster to Godzilla. And they have no idea how hard it is to stay abstinent and sober from heroin. And I know people have done it. There's people in this room that I know have done it, but it's really hard. It's incredibly hard. So I think educating patients is really important, and doing something about the ignorance about medication. And I also tell people in 12-step programs that there's nothing in the big book or the Narcotics Anonymous book that says that you can't get treated for other disorders or get treated for your primary disorder. So.
I would just like to say that there's also mind-body therapies that are very effective for treatment of substance abuse disorders, such as acupuncture, yoga, Tai Chi, massage, and I'm a big advocate for chiropractic medicine being covered by Medicaid, which Medicaid covers about a third of the state, and just to keep people off of pain medications in the first place. It's incredibly frustrating that we were even part of the RFP for the Medicaid expansion and then specifically taken out for some reason. I don't know why, but that's all. Thank you.
I'm a recovering judgmental pharmacist. I've been successfully destigmatized over the years. But I was one of the ones that used to look at a person when they were on a lot of medications and say, wow, this is a drug addict. I don't want to have anything to do with them. But I was able to now see how methadone and Suboxone really does help these individuals. I mean, from a 18-year-old little girl wondering who would even stick a needle in her arm, give her that medication, to see her a month later smiling and saying, I finally have a life again. And that's something that really helped to turn me around. But being a pharmacist, I didn't get any education about this when I used to go to pharmacy school. And I was wondering if that's one of the objectives of the committee, to go to the medical schools, the pharmacy schools, the nursing schools, and actually include this in their education also.
If you just look at the lethality and the devastation that comes from addiction, it should be way up there in terms of what we focus on in medical education and pharmacy education, et cetera. So thank you for your comments. Others?
Hi, everybody. We're going to get started with the Narcan implementation team. There's a little history behind the Narcan implementation team. It used to be called the harm reduction team, and we ended up changing it because our ultimate goal was to reduce overdoses, and of harm reduction, the only method that really reduces overdoses is Narcan. Now, some people consider medication-assisted treatment harm reduction, but we keep it in our treatment group. So that's why we changed our name to the Narcan implementation team. And I have two really excellent people here to talk to you. First, I have Mark Clark. He's a health promotion specialist with the Department of Health. He's done an extensive amount of work with helping people with HIV/AIDS. Right now, he's working in the Southeast Heights Public Health Office as a health promotion specialist. His work supports community engagement in the policies affecting health in the International District and in the county health councils in the Northwest region of New Mexico. And I'm going to introduce Melissa also. Melissa Hines, MPH. Melissa is a dynamo. I work with her a lot. She basically knows everything about opioids. And if you want to talk to somebody who's got her feet on the front lines, she works with the Department of Health. She's the injury prevention coordinator in the Office of Injury Prevention, which is in the Epidemiology and Response Division. So from 2004 through mid-2012, Melissa managed the hepatitis program within the Infectious Disease Bureau, during which time the program established Suboxone clinics and public health offices, and expanded harm reduction and disease prevention services on outreach in county jails across the state. And she did a tremendous job here in Bernalillo County. I already said some of this, but I'll say it again. Melissa currently works with the Office of Injury Prevention for the Department of Health, responsible for prescription opioid misuse, overdose prevention and policy development, and coordinates community-based planning efforts to expand access to naloxone. So she's the person going around trying to get all the law enforcement to carry naloxone. She's the person going around trying to get the co-prescribing projects going throughout the state, finding pharmacists that will carry naloxone, which is a no mean feat, and finding practitioners who will prescribe Narcan. And she does this, and I don't know how she has all the time to do it, but she's great, does a great job. And Mark does a great job too. So who goes first? Mark? Thank you.
Thanks so much, Harris.
Good afternoon, Mark Clark, Southeast Heights Public Health Office. And I want to say and commend you for being good troopers and staying with us all day for this. And if I may, I'm going to adjust the mic. Is that okay? Thank you. So from our initial summit in October of 12 now, the panels presented various indicators that we were going to follow up on, and that's what we did this last calendar year, starting in January of 14. So our overarching goal for the Narcan committee was to make Narcan normal in Bill's terms, and to make it readily available within Bernalillo County, whether you're a prescriber or consumer, but it's available at all points of entry. So our recommendations are from the original summit was the people being discharged from the MDC, and to increase the training and to dispense upon release from MDC. So the update on that is Bill and Jennifer have and Harris have been working with Lisa Simpson from the county in the interim government, and I'm going to defer to Virginia Chavez, who's presenting in our next session about the MDC updates as that'll be implemented going forward. Our second recommendation was the pardon and parole policy, or probation and parole policy, to allow people on parole they can be dispensed the naloxone. However, if they administer it, they would violate by association their parole. So the update on that is the Drug Policy Alliance is working in this legislative session to introduce an amendment to the Good Samaritan law and to increase the immunity at the scene of the administration of the Narcan, so no one will be in violation of their parole. And our next one is the law enforcement to carry naloxone, or as I put it, naloxone on patrol. And again, Jennifer and Bill have been meeting with Chief Eden during the year, and that's an ongoing basis to develop and get approved a pilot and to expand the pilot throughout the system here in MDC. And we would assist in that with the department's pilot programs through the Santa Fe County Sheriff's Department, as well as the New Mexico State Police, who are implementing that as well. And our next one was the expanded prescription authority, and if I may, I'd like to also acknowledge the managed care organizations who were at the table, and this was back in March of last year, working concurrently at the same time the expanded prescription authority was rolling out. The managed care organizations at the table were working to develop the Medicaid billing codes for the naloxone rescue kits. So that concurred with the hard work of Dale Tinker here in the New Mexico Pharmacy Association in it was Dale and Amy Backeritz who developed the training for the certification for the prescriptive authority, and he gets the gold star for doing the most. And I must point out also on the New Mexico Pharmacists Association's website, if you want resources for naloxone, they have an excellent resource under the naloxone resource tab, and it will be patient education information as well as the billing codes by managed care organization and the next trainings and all of that. So I really commend Dale for all of his hard work this year.
I'm going to butt in, but I wanted Dale to actually wanted to honor the Pharmacy Association for their efforts. The expanded prescriptive authority, to make sure everybody in the room is aware, allows pharmacists to directly prescribe naloxone to patients based on a protocol that Dale and colleagues wrote and got passed by the Board of Pharmacy. No other state in the union does this. This is remarkable public health work. So Dale Tinker, the New Mexico Pharmacy Association.
Oh, and the next one is actually the New Mexico Medical Board and Board of Nursing. If you look on their websites, they have posted in a guidance for healthcare professionals in prescribing naloxone. So like on one side of the guide is the indicators to help assist healthcare professionals to know how to prescribe this. And on the back side of the document, or two-sided document, is the patient information and the description of the kit and the patient education component of that. So that kind of coincides with the guidance is to increase the supply or the demand by getting more healthcare professionals to prescribe the naloxone and increase the demand for it. So we still need to have more consumer demand in order to get more pharmacies to stock and dispense the product. Another our October surprise this year was the sole manufacturer of the naloxone doubled the price, and so that's kind of affected the reimbursement rates through the Medicaid program. And also each individual managed healthcare organization has a different contractual reimbursement rate as well, which might skew the ability to get the product out to a wider audience. And on the tables at noon, we passed out a quick little handout that I made yesterday and missed the deadline for the packing party. But this addresses the naloxone services. And through our harm reduction services at the Department of Health, it's not just dispensing the product, it's also the patient or the consumer education, because we'd like not only the person receiving the prescription, but also family members and friends to know how to administer the product, because the person receiving it may be the one overdosing. So their family members or friends would have to know how to do that. So I've listed on this handout on your table, and if you don't have one, we'll put it on the website after the conference so you can have more copies. So it lists kind of like the 3 public health offices, the Midtown office, South Valley, North Valley, as well as the pharmacies that are currently stocking and dispensing the Narcan, which is Highland, Medicine Chest, a Smith's Pharmacy in the Southwest on Arnall, and the Walgreens Pharmacy in the Northeast Heights on Manal, and the Walgreens on Northwest Coors, as well as healthcare for the homeless and Casa de Salud. So, and if we go like in an hour, well, 2.5 hours to Utah at Central, you'll see a 12-year-old Winnebago that's been doing outreach for 12 years on the street as part of our harm reduction program through the old Sanford Health Office, which is now called the Midtown Health Office. And that's been a long established street outreach, which is a community collaborative with not only communities of faith, but also other contractors through the harm reduction programs. So I know we've been doing STD, hepatitis, HIV screenings and as well as vaccinations for hepatitis out of that van. And now the nurses from the Midtown clinics are going out on Thursday evenings to dispense the Narcan to people through the van. So that's an ongoing effort that's been going on since 2002. And Art Salazar there in the corner, a former DOH worker, he's now with the Truman Clinic at UNM, was one of the initial founders of that outreach. Did you want to talk about, I'm going to skip the next two because I was on that. If you want us to talk about the data slides now. Because that was part of it.
Oh, okay.
Okay.
Hi, everyone. Good afternoon. Along with recognizing persons in the audience, we do have the Department of Health Harm Reduction Program Overdose Prevention Coordinator in the back, Josh Switek, if you want to stand up. We have a really heroic public health naloxone program in this state that Harris described earlier with this slide, and I'm going to do my best to tell you a little bit more about that slide. So let me see about this. It's so intimidating. Luigi, why didn't you do this? So what this shows you is over time, the dramatic expansion of public health naloxone going out by year. The bars indicate reversals. And since Dominic's not sitting there, I'm going to go on ahead and say, we saved some lives. We saved some lives. So it's very important, thank you. I did not. These are my great public health colleagues. But the point is that we don't scientifically want to say save lives, because the truth is somebody might have lived through an overdose, and so it's not scientifically correct to say that. We refer to them as reversals. But as you can see, from 2010 to 2014, the right-hand bar is the statewide figure. So we, in 2014, and we haven't even completed the data, I don't know what month we're through, Josh. What month is this through? The October? We already have 770 reversals statewide. So you can get a sense of why I'm describing this program as heroic. In the case of Bernalillo County, 119 of those 770 reversals in 2014 so far. The numbers, the lines that come across the graph describe the numbers of persons enrolled in the program. So as you can see, in the case of between 2012 and 2014, look at the expanded numbers of reversals done and the really high volume of enrollees. In Bernalillo County, the enrollees, am I reading that correctly, Luigi, that in Bernalillo County, enrollees in 2014 were 553? Okay. I actually wanted to start my talk with something that was a little bit brighter than a data slide, so I'm going to pull back for just a second. And say to you that it's a real honor to be presenting up here right now. The room is full of advocates, activists, thinkers, physicians, and heroes. And thank you very much. A whole lot of amazing public safety folks as well. Really good to have you here. And it's been a long day, and it's in the middle of the afternoon. And so I just want everybody to stop for a second and bear with me, public safety. You can do this too. I just want you to take a deep breath. I just want everybody to pause for a second. We're presenting about 7 recommendations that came out of a room of folks very much like yourselves a year and a half ago. And we're talking about naloxone as if it is the one answer. I want to frame this with saying it is one small piece, just as Chief Sperling was talking to me before I came up here. It's one piece of a very complex response to, as was pointed out again and again today, a very complex and tragic epidemic. So we're counting naloxone enrollees, and we're counting naloxone kits, and I'm going to talk to you about recommendations about how we might expand access to naloxone. But that is just one part of a much broader coordinated response. And we only get to that coordinated response by staying at the table and inviting others to the table and continuing this conversation and continuing the conversation and coming up with more action steps and finding out what doesn't work and going back to the table and identifying more. And that's what this hardworking team of planners have been doing for 15 months and are committed to continuing that process into action. So thank you very much. I'm really honored to be here. So what way forward? We set a goal for the summit. I think it used to be called a headline goal. It's the hazards of somebody editing your slides before you get up here. The headline goal of the BurnCo Opioid Accountability Summit is to reduce unintentional overdose deaths in Bernalillo County. And we have, in the course of the last couple of years, the department has led on a very important and strategic shift. We have, since 2001, led the nation in responding to heroin overdose through our syringe exchange program. And lo and behold, the prescription drug epidemic took off here just as fast as it did in any other state, and much higher numbers of persons were dying from prescription opioids than from heroin. And we didn't really have interventions for them. We had tremendous services available for through syringe exchange, and not a lot in the clinics, and certainly not in other settings. And so the strategic shift has been, how do we get naloxone into the hands of persons who are not injecting, but who are using pills, or and not wait until they lose their pills and wind up at syringe exchange because they're turning to heroin. But we have pushed on this shift, and that's what Harris was describing. We have co-prescription pilots going on in a number of communities. Several representatives of our co-prescription pilots are here today. We have advanced some on public safety and trying to expand access to naloxone. And a part of that process, and a part of what informed that shift, was what was happening in Massachusetts by another heroic doctor. Our Miriam Komarmi in Massachusetts is Alex Wally. And what Massachusetts has done has gathered, they have been able to conduct community-based overdose prevention work with naloxone and studied it and gathered the evidence that showed a direct association. It's not really rocket science, but it's really important that we've proven it. A direct association between expanded distribution of naloxone and overdose death. In the smallest communities, in several small communities in Massachusetts, the more naloxone that they pumped into that community, the faster and lower their overdose death rate dropped. Alex Wally signs a standing order so that statewide, any individual who is trained by their Department of Health can dispense this life-saving, reversing medication in community settings all across the state. Libraries, schools, college campuses. And the more Narcan they get out there, the more they are able to drop their overdose death rate. Our headline goal is reducing our overdose death rate. So I would submit that the Massachusetts model is something that we want to look at and is something that we are attempting to accomplish here. The more Narcan we get out, the faster death rate is going to come down. I am convinced of that. I don't think it's just about Narcan. I do see it in a much broader setting, but I also believe that the more medicine we can get out there to counter death, the more we're going to counter death. So the medical model, the Massachusetts model, I mentioned Alex Wally issuing a standing order They have naloxone distribution through their Department of Health. They have naloxone able to be stored in non-licensed community-based organizations that don't necessarily, hold on to it, Dale, hold on, have a pharmacy license, okay? But because there's a coordinated effort to alter rule and regulation and expand access to this very important medication in a time of terrible tragic death and epidemic of death. In Massachusetts, that medication can reside on the shelf of a parent organization. Jennifer, I'm thinking of the healing addictions in our community. I want to ship you Narcan. I want to pay a pharmacy to get Narcan on the shelves of Jennifer's organization so that there can be trainings with other parents and other grieving family members or other community members so that they're in a position to save an individual who is in opioid overdose. That's what they've done in Massachusetts, and we took one step toward that very successfully in September, when the New Mexico Medical Board, can you hit that again? When the New Mexico Medical Board unanimously endorsed a standing order for us to use in New Mexico for naloxone. It was a direct cut and paste from Alex Wally's standing order. Alex Wally from Massachusetts. His standing order resides on their Department of Public Health's website, by the way. That's how accessible it is. So how do we increase, if increased naloxone distribution is equated with reduced overdose death, if reduced overdose death rate is our final, good to see you, Andrew, is our final headline goal, Andrew Gans from the Infectious Disease Bureau, then how do we increase distribution of Narcan? I think that's a central question, and I have some answers. What do I have for time? Oh, okay. But then we'll still have time for questions. We need to expand resources so that Andrew and Dominic Zerlo and Josh Swatek, doing the heroic work that they do in outreach to injection drug users around the state, are assured and expanded. I'm not supposed to be doing that as a Department of Health representative, but there are other ways that we can expand it. In other words, it doesn't all have to be government money. There are ways. We work with some of the finest. They're in here. Healthcare for the Homeless is here. There's some tremendous community-based organizations. I forgot Dominic, and I want to throw this out there. He crunched some numbers for me. The idea of this standing order and storage issue, if we can resolve it, and we are working to resolve it, that is working with the Board of Pharmacy to consider rule or statute change so that naloxone is not in such a restricted place. And if we get there, the difference between the numbers of dispensers of naloxone today and when we get those rules and regs figured out is dramatic. The difference is, I think you mentioned today, we have 25 dispensers of naloxone. Public Health could have as many as 400, am I right? Dispensers of naloxone, if we can push through and work collaboratively with the Board of Pharmacy and the Medical Board and make happen here what they've been able to make happen in Massachusetts. We also, and I guess it's, did it just go away? That's a bummer. Okay, now let's try this. And then we hit it again. No, don't hit it again. Oh, yeah, it all went away. Yeah, can you tell I didn't create this presentation? No, I actually wrote it, but I got total technical assistance from a young and brilliant MPHer by the name of Luigi Garcia Saavedra. And so I'm sorry that I'm stumbling through this. I love the way they appear and disappear, but sometimes they disappear when I don't want them to. We need to reduce the administrative and rules barriers for naloxone, and that is a part of what I just described. There are ways to make this happen. Naloxone is a medication that deserves to be in the hands of every community member who knows someone or lives with someone or cares with someone who is at risk for opioid overdose. Now, I was going to call it a benign drug, and I'm thinking now of the great conversation I had. One of the many benefits of this extraordinary collection of people is that I can have a hallway conversation with somebody like Frank Soto with Albuquerque Fire. And we can talk about the instances where the administration of naloxone is not so benign. Somebody coming out of an opioid overdose may not consider that a very benign situation. It can be a pretty tough situation. It can be a combative situation. It's a complex issue. We've got to talk about what's the appropriate intervention at every step. I still believe that putting the rescue medication in the hands of more individuals is going to reduce our overdose death rate, and I think that's the right thing to do, however we can make it happen. And I also hope that my bullets don't disappear. We really need to support the great work, the progress that has been made with the Board of Pharmacy and the Pharmacy Association with rolling out expanded prescriptive authority so that we can have pharmacy-based overdose prevention training and naloxone distribution. In part, we can do that by working with the Human Services Department. We had an issue that I'm very happy to report here. Many of you didn't know it was an issue, so maybe you won't be as happy as some of us that are. When Narcan price increase doubled, we didn't have that quick of a response. It never happened. It's not a quick response. No bureaucracy responds quickly. Let me just say that. You know, we do the best we can, but nothing happens quickly. Particularly in record systems. And in October, when the drug company doubled the price of naloxone, our state office of Medicaid and our managed care organizations were not able to overnight increase the amount that they were paying for that naloxone. As a result, our independent pharmacies had to just step back from the plate or take a loss. In other words, the increased cost of naloxone meant, and they weren't getting paid from Medicaid that same amount, meant that they couldn't really do business. As somebody from Carlsbad told me, under no uncertain terms, I'm not going to take a loss. I'll serve my community, but I'm not going to go bankrupt. So they stepped back. But as of this week, Dale Tinker was reporting to us, and is it okay that it appears that 3 of the 4 managed care organizations are paying commensurately for Narcan. So if all that just sounded like Greek to you, I mean, so this is the deal. You can, if you're covered by Medicaid, and if you, Miriam, write me a prescription and I'm covered by Medicaid, I can walk into 2 different Walgreens in Bernalillo County and fill that medication at no cost to myself. And that pharmacist has been trained by Dale and a team of experts on how to educate a patient to pick up that naloxone. So getting Medicaid reimbursement and expanded prescriptive authority and pharmacies that are willing to step up to the plate, and to Walgreens' credit, they have 6 stores across the state that have stepped up to the plate. We need to help continue to support that. We can put together teams of people. I think we already put together a team. We sent out Harris as a team of 1 to talk to pharmacies here in Albuquerque. We need to do more of that. Pharmacists need technical assistance, not unlike the buprenorphine training. You can't train somebody and then say, go off and conduct this service. Pharmacists need follow-up. They need support, and we can help to provide that to keep pharmacies prescribing, and we can also convince more pharmacies to stock naloxone and more pharmacists to get trained to prescribe naloxone. And we want to continue to support a naloxone co-prescription by medical provider. The co-prescription pilots are where naloxone is delivered in conjunction with prescription opioids for chronic pain, or a number of other screening possibilities. If you're on Suboxone, you're on any opioid replacement therapy, then you get it. Or do you just know somebody who's at risk for naloxone? So our co-prescription pilots are taking place in Taos and Santa Fe, Albuquerque, and Roswell. But any doc in this room, and there's a number of them, but Julie Muche over there, I just want to give some kudos. One of the first docs I knew who was prescribing even before we could find a pharmacy to carry it. And the pharmacy called me and said, I can order this, but this Dr. Muche wants me to get this for her patient. But how do I talk to the patient, and who do I, so we put all those pieces together even before we had Medicaid coverage and expanded pharmacists. So every physician in the room and any physician that you all know, talk to them about co-prescribing naloxone. Consider that. Consider following what the medical board and the nursing board promulgated in guidance. And then ask those boards to promulgate that guidance again. That means, you can tell I've been in state government too long, send it out again. Right, recirculate the naloxone guidance. We have built the best system here for responding to the epidemic. For good reason. We have a whole lot of people dead as a result of our inability to provide sufficient care to them, in my humble opinion. So we have every reason to build the best system, but we have pharmacy-based, pharmacy prescription, we have Medicaid coverage, and we have one of the highest distributors of public health naloxone in the country, highest reversals in the country. So we have a system put together, integrated, could have tremendous impact. And we need people to access that system. We need more than 6 pharmacies, or no, we're at 5 pharmacies in Albuquerque. More than 5 pharmacies and more than 6 docs. We need 100 docs, and we need 20 pharmacies. So let's make that our goal for the next summit. Again, continue with presentations and awareness-raising initiatives to the medical society. These are all our recommendations for further action. How can we make this particular recommendation move? Talk again to healthcare provider boards and healthcare professional associations. I just have to back away a second from the slides. None of this work happens unless we sit down together and make that change. And I'm reflecting here on our Taos colleagues, just remarkable team over here, Ricardo, Julie, John Hutchinson, all from Taos Alive, and one of our most active, the hands down most successful to date community co-prescription pilot initiative. And John is always my mentor and always helps to keep my head clear when we reach a setback, and we reach many of them. And the point is that we've just had to continue to try to do it, because the barriers around naloxone are crazy if you think the way I do, that this is something that we ought to be moving on more quickly. So even when we have all the providers in the world ready to roll, and we have a pharmacist ready to roll at a hospital that's stepping up to the plate, and an advocacy group, and we have drug-free community funding, and we have the school district, and we have the police, and we have the fire, and we have Conservation Corps, and tremendous capacity in this community, and still barriers to moving forward. 5 or 10. And the way that we've worked through those barriers is one by one. I know that sounds kind of trite. 7 different clinics, and literally 7 different ways of figuring out how to get that Narcan off of their drug shelf and into that patient's hands. Sometimes it's a med tech, sometimes it's the doc, sometimes it's a nurse, sometimes it's a volunteer. You have to find out what the resources are, figure out who's willing to help and convince, and then you figure out that model, and then you've got that one clinic checked off. And it took 2 months, but that's one clinic. And that's the way he's built, that's why they've built what they've built with the tremendous network in Taos. But it is a one-by-one kind of a thing. And that's why these presentations are so important, because we have to get eye to eye with leadership and talk to them about the reality of what happened with the Taos Rescue Kit a month and a half ago. A 13-year-old was saved. His life was saved from Narcan. We've had multiple reversals with the co-prescription pilot Narcan kits. Not a one of them to the patient to whom it was prescribed. That's success, I assure you. We're getting Narcan into communities, and the Narcan is being used. What's important is that the Narcan is being used, that the community is being educated around the risks of opioids, whether it's heroin or OxyContin, and the community is being told that again and again, as John often says, you know, I care about you. I want to tell our patient, we want prescribing guidelines because we care about you. The community loves you enough that we want you to carry this medication. And with that medication, there's a kid in middle school today who would have been buried. We need that medication in the hands of more people. We need to build consumer demand. That's a part of everything that we're doing, and that's a part of what the Bernalillo County Planning Group and the Santa Fe County Planning Group and the Taos County Planning Group is doing with these conferences and with our communications with docs and with the presentations that Harris was describing on that previous slide that we want to make happen, is we are building education and awareness so that people ask for this medication. You know, that supply, that chicken or egg thing, it's tough to get pharmacies to carry a medication that nobody's asking for, you know? We need to build awareness, train on overdose prevention, how important it is to recognize that the training is with the medication. It's never just the medication, right? It's about training people around overdose prevention. But we need to increase consumer demand. How do we do that? Well, I was thinking about that big screen at the pit. And that's what I had in my slide. And then my boss said, I think you should say the electronic bulletin board at a sporting venue. So anyway, but I thought that the big screen at the pit might resonate more, I don't know. So we need some high profile engagement so that people are asking those questions. And we need to engage in discussion with our school health nurses and our senior centers and our homeless shelters, and talk about, and our treatment facilities. Do you have Narcan? If you don't, why don't you? Can you? How can we help? You have a place to store it. Can we get the Board of Pharmacy to approve? Or you can, in New Jersey, bad language notwithstanding, but this is what they did in New Jersey. I mean, we need to raise the profile. We need a billboard about Narcan. I look forward to the discussion. Thank you so much.
Hi, I'm Mary Murphy. I have a little bit more good news to add to this presentation. I've been working with Josh Swatek, I apologize. And he is with Department of Health Harm Reduction. Obviously, I'm a harm reduction specialist with the state of New Mexico. And we've been working with George Davis, who is a psychiatrist at Juvenile Justice. And we've trained the guards, and we've trained all of the medical staff in Narcan administration. And who else? The educational staff has stepped forward. We met with the superintendent of juvenile justice, and everyone's really excited, and I have every reason to expect that we should be able to help them dispense Narcan to adolescents leaving their reentry, what is it called? Their reintegration program upon release from their reintegration program, to have it in hand, have them trained on how to use it. And I don't know when that's going to happen, but there's a lot of very excited people, and it's looking good. So there's that. Yeah.
Thank you.
And I have a correction for Melissa's presentation.
Oh, yes.
Yeah, she says that she is not a lifesaver like the rest of us. And I want you to know that I know the names and the faces of the people that you helped through the work that you've done.
Thank you, Mary.
Thank you.
Yeah, thank you. I am so glad to hear about that juvenile justice piece. You know, we've had tremendous tragedy of children dying in custody. Dying in custody, you know, for lack of a crash cart Narcan. So we're working on those initiatives too, working in Taos, working to make sure we have crash cart Narcan in the Taos County Jail, for example. Santa Fe County Jail has it in hand already. We're dispensing from Santa Fe County Jail on release to detainees who've been trained during their incarceration.